independent study were acute neurologic disorders, things that happen right away. And what we're going to see is many of these disorders have a slow onset, potentially a lifelong outcome. And particularly when we get to the end here, where we talk about the neurodegenerative disorders, it's a little pessimistic because a lot of these brain disorders have very little that medicine can do other than identify the problem and sort of give a prognosis. But in terms of changing the outcome of the disease, some of these we still don't have anything really that we can do about that. All right, so first up, hydrocephalus. So this is water on the brain is how people typically refer to this. This is any excess of cerebrospinal fluid. You know, in the adult, the brain is contained in a fixed volume. You know, the skull cap or the cranium confines the size of the brain. So anything that adds any extra volume to the skull is going to have a tendency to compress or squish the brain. And that's essentially what hydrocephalus is, compression of brain tissue because of an excess of cerebrospinal fluid. Now, this is a disorder where the presentation is very different in the very young and everybody else. So in infants, because their skull bones haven't knitted together yet, their skull can actually enlarge to accommodate this extra fluid. Now, it gives them a head size or a occipital circumference that is greater than normal, and it's one of the reasons why pediatricians and family practice doctors measure babies' heads, is to make sure that we don't have a hydrocephalus situation. So there's two causes for hydrocephalus that are very different. So there's non-communicating and there's communicating. Non-communicating hydrocephalus is an obstruction. You know, CSF is made primarily in the lateral ventricles, and then it flows through the other ventricles, eventually out into the area outside the brain, but inside the skull, and that's where it ends up getting absorbed. So when we have a blockage in that system, CSF continues to be made, but it can't get anywhere. It can't get to the arachnoid villi on the inside of the skull to be reabsorbed. So you end up with more and more fluid. That fluid creates pressure, and then that pressure literally squeezes the brain. Left untreated, hydrocephalus will destroy the brain. I mean, essentially all you'll be left with is a narrow little rim of brain tissue and great big ventricles instead. So the obstruction compresses the brain and the blood vessels. Typically, the non-communicating variety is a congenital defect, either from a problem with the brain's development or simply a stenosis. A stenosis just means that the canal through which CSF passes is just too narrow. The other version of hydrocephalus is communicating. We call it communicating because all the ventricles can communicate with one another. In other words, all the pathways are correct. So in communicating hydrocephalus, the problem is with absorption. So it's not an obstruction. It's that in the normal, as CSF is produced, CSF is reabsorbed at another site. If that absorption, if there's a problem with that, you're going to result in the same thing. CSF is going to build up, cause pressure in the brain, increased intracranial pressure, and eventually it's going to start to squeeze the brain out of existence, essentially. So communicating hydrocephalus usually presents in older children and adults. Now, it can present in the neonate, but it's much less common. If you have neonatal hydrocephalus, it's usually the non-communicating variety. But the symptoms are the same. So increased intracranial pressure that eventually will result in brain damage. So this is sort of the normal. You know, CSF is formed in the two lateral ventricles. It flows into this central ventricle and then out, and then eventually around to the outside of the brain and spinal cord. If there's an obstruction, or if the CSF is not being absorbed, essentially the ventricles keep getting larger and larger. And eventually they squeeze this brain tissue until it's just a little narrow rim, and you can imagine that that would have significant neurological deficit that would go with it. So the signs and symptoms here, they're the signs of increased intracranial pressure. because as the CSF builds up, it raises the pressure in the skull, and we see some of these typical symptoms of increased ICP, like a sluggish pupil response. The scalp veins, particularly in babies, appear dilated because of the increased pressure. In infants, you get lethargy, irritability, problems feeding. The classic sign is the sunset sign in the eyes. And what they mean by that is, if this is the eyeball, in babies with increased intracranial pressure, it sort of looks like this. Their pupil, or their eyeball, is being pushed down and out by the pressure behind it. So we end up with this appearance like this, where we don't see the whole, the pupil, or the iris is not in the middle of the eye. It's sort of like the sun going down. That's the sundown sign. And then babies have the ICP cry, which is a very high-pitched cry, particularly when they're moved. Because when your intracranial pressure is high, it hurts to move your neck in particular because of all that pressure that's there. So hydrocephalus has to be treated as quickly as possible because that buildup of CSF is very quickly going to start to destroy brain tissue. And brain doesn't grow back. So we address this very quickly. Easy to diagnose on a CT scan or an MRI. It'll show an increase in the size of the ventricles and possibly the site of obstruction. And then the treatment is usually surgical. So if they can identify the obstruction, they'll remove it. But most of the time they can't, or the surgery to remove the obstruction would be more damaging than the other option. So the other option is called a shunt. And you will encounter both adults and children who have a CSF shunt. So essentially what they do there is they run a tube from inside the lateral ventricle. They run it up, down along the side of the head, down the neck, down the chest, and then they insert it into the peritoneal cavity. So as CSF is made, it ends up dumping into the peritoneal cavity and then getting reabsorbed. Now, one of the issues in kids is the distance between head and peritoneal cavity, of course, is going to get bigger and bigger as they get older. So one of the very common surgeries is called a shunt revision. And that is, as the child gets older, the neurosurgeons have to go back in and extend the shunt. So normally what they do in babies is they put sort of a coil of tube either in the chest or in the peritoneal cavity so that the whole shunt doesn't have to be replaced. It just has to be sort of unwound until they get to be adult height. So it has to be revised. All right. Anybody who has a shunt like this is at increased risk for meningitis because there's one more path for bacteria to get into the CSF and into the meninges, and that's from the peritoneum up into the CSF. So I always worry about these kids in terms of shunt malfunction, because if this tube gets blocked, hydrocephalus is going to start to build up again, and we worry about them in terms of infection because they have one more path for that. So the treatment there is the same, whether it's communicating or non-communicating, and that is get rid of the CSF. And the easiest way to do that, dump it into the peritoneal cavity, and then it'll get reabsorbed just like it would at the arachnoid villi in the brain. All right, so nice and easy, hydrocephalus. Typical board presentation is you have a child with some of those symptoms and an increasing head circumference. Because while babies' heads do get bigger, they don't get bigger real fast. If a kid's head is getting big real fast, you want to work them up for hydrocephalus. All right. Cerebral palsy, this is one everybody's heard of, CP. This is a group of disorders that cause motor impairment because of a cerebral problem. So we all know that the brain controls our skeletal muscle and our activities. So damage to the brain often presents with problems with motor control, either paralysis or spasticity or a loss of control. So CP is not so much a single disorder as a final common pathway for lots of different things that can go wrong with the brain. So genetic mutations, anything that damages the brain can cause CP. So genetics, abnormal development of the brain, so a fetal malformation, infection, hypoxia, anything that causes brain damage. So very often this is associated with perinatal trauma. You know, for the human being, giving birth is not exactly an easy affair, and it's stressful for the kids. And in some bad outcomes, the kids may have a small amount of hypoxia, or they may even have a small brain bleed from that, and that can lead to cerebral palsy later on. So the damage, it is important to note, though, that just because a child has cerebral palsy, it doesn't mean that the damage occurred at birth. That is often the assumption. That's what all the lawyers want everybody to think. But the truth is, you'd have to prove that, because the damage could have occurred during the pregnancy. It could have occurred, early in the first couple of months of life. So CP is really just the effect of brain damage on the motor cortex. So for lots of different reasons. So some of the outcomes: spastic paralysis. This is you don't have voluntary control over a muscle, but instead of being limp, it's tense. So we call that spastic. And it results from damage to the pyramidal tracts, which are the upper motor neurons of the brain and the motor cortex. Other sites of damage cause dyskinetic disease. This is where the motions are strange. So things like coriform movement is sort of snake-like movement. This is people that don't have fine control over their skeletal muscles because of damage to those coordinating areas of the brain. If the cerebellum is involved, you'll get ataxia, so loss of balance and coordination, or a child who struggles to walk because they can't keep their balance. So CP can affect multiple places in the brain, so its symptoms or its outcomes vary according to which region of the brain was affected. Typically in CP, after the initial workup, that's known. You know what areas of the brain are damaged, and then you can take your knowledge of neurology and sort of apply that and guess what their symptoms and prognosis are going to be like. Intellectual function can, capital letters, can be affected, but is not necessarily affected. It's a very dangerous assumption to assume that a child or an adult with cerebral palsy has any kind of cognitive deficit, because they may not. It may just be all motor. So you can't assume any kind of reduction in intellectual function, even though that can co-occur along with cerebral palsy. Brain damage is brain damage. But many people with CP don't have any cognitive deficit. Seizures, anything that has affected the brain in a negative way can lead to seizures in some people. Sick or damaged brains have seizures, as we'll talk about in a minute. So CP and seizures can sometimes go together. And sometimes very mild cerebral palsy is only picked up when a seizure disorder presents, and the patient gets worked up for that. So treatment, brain doesn't grow back, so we can't fix this. But in the modern day, what we do is we try to throw therapies at the child or at the adult to try to get them to as high a level of motor functioning as we can. So, typically babies who have CP, they'll start on an occupational therapy, physical therapy regimen very early on, like in the first 6 months of life. Then when they're getting to be 3 or 4, they'll be in speech therapy, so we sort of help them as much as we can, even though we cannot fix the underlying problem. All right, so hydrocephalus, cerebral palsy, seizures. We could talk for 2 weeks about seizures, so this is like the very condensed version. Essentially, a seizure is an uncontrollable discharge of neurons in the brain. Now, it may involve the whole brain, it may involve just part of the brain. And we classify seizures according to either their location in the brain that they're occurring or which of the clinical patterns they fall into, as we'll talk about in a minute, like right now. Okay, so this is the classification method. And very often, patients, particularly patients with known seizure disorders, they'll come in and they'll know exactly what kind of seizures they have. So it's important to sort of know this list. So the first division is partial versus generalized. This is focal or part of the brain versus the whole brain. So in the simple partial seizure, we have just part of the brain that's affected, and consciousness is not impaired. So we can have motor, sensory, autonomic, or psychic seizures. And this doesn't mean that you can tell the future. This involves higher order brain functions. Suddenly not being able to remember your name, or suddenly not being able to remember to know how to talk, for example. So those are simple partials. They're sort of the easiest. They affect just one part of the brain, and they don't spread. They're usually the result of brain damage. An area of the brain that controls one of these things was affected either by a stroke or hypoxia, ischemia, something like that, so the brain is damaged there. In the partial complex seizure, consciousness is impaired. Now, that doesn't mean that they're unconscious, like you see in the generalized seizures. It just means that they're not fully awake during the seizure, or they have a change in their level of consciousness. So the common ones here are temporal lobe seizures, cause a kind of version of a memory flashback, and psychomotor seizures are sort of high-level motor seizures that cause some impaired consciousness. And then some people have partial seizures that lead to generalized seizures. So one of the important distinctions here is, how did the seizure start? If it started about one thing and then became a generalized seizure, then that's a partial seizure that leads to a generalized seizure. In a pure generalized seizure, it starts all at once. So the whole body, the whole patient, the whole brain is affected immediately at the beginning. Because there are lots of people that have partial seizures that then lead to generalized seizures, but the treatment of the two are very different because of their likely cause. A partial seizure is usually a localized area of brain problem, and a generalized seizure can be sort of a whole brain problem. All right. So in the generalized seizure, both hemispheres are affected. So you're talking about the whole brain, and these are profound. They affect the whole patient's behavior. The classic generalized seizure is the tonic-clonic seizure. This is the one you see on TV sometimes, and this is the one you may have seen in a hospital or an ER. They're very stunning to see because the patient's tonic and clonic. So they tense all their muscles, and then they relax all their muscles, and they repeat that behavior. So the general public will call this a fit sometimes, and it's a real impressive thing to see because the patient is literally just shaking their whole body. So that's the tonic-clonic, also called the grand mal, or very bad seizure. Absence, that's how you say this, not absence, but absence, because it's a French word. Absence seizures usually happen in kids, and they are difficult to see. What happens here is the child is engaged in their normal activities, and then they just stop for a few seconds, and then they go back, and then they finish whatever they were doing. So these absence seizures are sometimes not identified until the kids get into school, because when kids are playing at home or in daycare, people don't pay that close of attention. But in school, if the kid sort of stops in the middle of what they're doing, that's a sign of absence or petit mal seizures. They're relatively easy to treat. The difficulty is diagnosing them, because people who have absence seizures and don't get diagnosed, they're literally missing like half of their waking life because they're not really there. They're in a seizure, not in a state of consciousness. So we ask a lot of questions about this, trying to identify those kids who have it. Myoclonic seizures are sort of a jerk. It's a single jerk, and then often the patient goes unconscious. Infantile spasms are a version of tonic-clonic seizure that affects infants. Atonic seizures is where people go flaccid, so they just sort of collapse without any shaking. And then the febrile seizures are generalized seizures that are associated with fever, particularly in kids. Most patients outgrow febrile seizures. Some go on to have a seizure disorder of another kind. But by itself, a child with a fever who has a seizure is not a huge concern, particularly if they've had one before. The treatment there is to prevent fever. If you prevent the fever, you prevent the seizures. All right. So seizures can either be idiopathic, you're born with it and nobody knows exactly what the cause is, or they can be secondary to something like cerebral palsy or brain damage or stroke, something like that. They either result from an abnormality in the brain or, in some cases, systemic causes. So like a calcium level that's very, very high or very, very low can trigger seizures. Same with sodium, potassium. So it may not be the brain that's the problem. It may be the person's metabolism or electrolytes that are the problem, and it's making the brain sick enough to have a seizure. All right. Most seizures are chronic, but every once in a while a person will have a temporary issue with a seizure. That's pretty uncommon, though. And if you have one kind of seizure, you're more likely to have other kinds of seizures, because already there's something wrong with your brain. It doesn't work exactly right, or you wouldn't have seizures. So if you identify one type of seizure in a patient, you usually educate them about the other types, because they may, in fact, have those at some point in the future, too. All right. We're going to skip some of these because we're going to try to get out here early. Seizures diagnosis is usually with EEG. This is electroencephalogram. Basically, the brain is wired up with a bunch of electrodes, and the neurologist looks for specific patterns that are associated with different kinds of seizures. The EEG is localized, so they may be able to tell you in which place of your brain the seizure is originating, and that can then lead to further workup like an MRI looking for a structural abnormality. Treatment, if there's a cause, obviously you treat the cause, because seizures are bad. They're hard. They stress the brain. A seizure that doesn't stop can actually cause brain damage through ischemia. But if there's no primary cause, in other words, the patient is otherwise healthy, then we start in on the anticonvulsant drugs. And here again, this is a very large class of medicines, and it includes a lot of medicines that people are not exactly sure how they work. They just have learned empirically that they prevent seizures. So we're not going to get into the different medication types there, but there are lots of different ones, and the choice of which anticonvulsant very much best left to a neurologist, somebody with a lot of experience with those. All right. Here, answer the student number question, and then we'll do this one real quick. 6. I have 11 people in the room, and I have 9 people who've answered.
Oh, I have another question.
The student number question?
Oh, I already answered that.
Okay, that's the one we're on. All right, come on, jump in there. There we go. There's got number 10. And I got one more. All right, I've taken attendance, so we're going to move on so we can get out of here. Okay, email report. All right, so seizures that involve both hemispheres of the brain. What do we call those? It's okay. All right, that's the 9 I have in the room. Correct answer there, D. Generalized seizures involve both hemispheres. So partial seizures are focal seizures, so those two are the same. That means there's only one part of the brain that's affected. And then we divide the partial/focal into simple and complex. The simple partial seizure, there's no change in consciousness. There's just either a motor effect or a sensory effect in the brain. In the complex partial seizure, there is an alteration in consciousness. So that's the difference there. All right. And then into the pessimistic part of the talk today, the degenerative disorders. So these are disorders where the central nervous system over time develops increasing levels of problems in various areas. Okay. So multiple sclerosis, which is probably one that you've all heard of, maybe even some of you have taken care of patients with MS, its root pathology is progressive demyelination. So we know that myelin speeds up nerve conduction. And in some areas of the brain, that speed up is critical because without the rapidity or the fast transfer of information, the system basically can't keep up with what it needs to do. Now, the interesting thing, and in some ways unfortunate thing about MS, is it doesn't follow a particular pattern. And in addition, we don't really know what causes it either. So demyelination can occur anywhere in the central nervous system. It can occur in the spinal cord, it can occur in the brain, and it can occur anywhere in the brain. So MS is a disorder or a disease that has a very wide presentation. Some people have serious, degenerating, debilitating MS at a very young age. Some people have MS that sort of comes and goes over time. And some people live to be 70 or 80 years old without a lot of significant neurologic impairment. So it's a strange disorder because its presentation is so broad and so wide. So this demyelination affects it can affect motor, sensory, autonomic, basically anywhere in the brain can be affected by MS. So in the earliest lesions, typically MS presents in the second decade of life, or I'm sorry, the third, so between your 20s and 30s, that's usually when it presents. And at first, the lesions trigger an inflammatory response, which often makes the initial problems with MS more severe than some of the exacerbations later on. So you get an inflammatory response. Eventually, you get plaques that form in the brain. These are areas of demyelination and inflammation that are larger than the earliest lesions that we see are. And they can vary in size. So they can really occur anywhere. So MS, the initial attack, so to speak, or initial neurologic deficit that gets identified as MS may go away. The neural function in that area may return as the myelin gets laid back down after the inflammation has occurred. But eventually, more areas of demyelination occur and the effects become irreversible. The brain does not heal very well at all. It can grow back some myelin, but not with repetitive insult like you start to see with multiple sclerosis. So this is a disorder that is marked by recurrences. You'll have the patient will have a new neurologic deficit, and then several months later we'll have another new neurologic deficit, and on and on and on. So it literally sort of degenerates the central nervous system. So the cause is unknown. People have speculated that it might be autoimmune, the body's own immune system attacking, nutritional deficit. Some recent research says that it's a change in blood flow to neurons, but the bottom line is we really don't know what causes it. There does seem to be some genetic component. It runs in families, as well as an immunologic component. So people who are close relatives of an affected person are at a higher risk. So that suggests both genetic and environmental parts. So signs and symptoms. Again, this is some may apply. This is like lupus in some ways. There's all kinds of different things that can pop up. So blurred vision, weakness, double vision. A scotoma is a spot in the visual field that's black that you can't see. Dysarthria is pain in the joints. Paresthesias. Progressive weakness and paralysis of the upper limbs, loss of coordination, loss of bowel and bladder control, chronic fatigue. So if you get the sense that this is a pretty diverse and wide list, it's because it is. You just have to think of MS as anything that the CNS does, multiple sclerosis can affect or cause a deficit in. So this is just showing you some examples of the different kinds of lesions. A cerebellar lesion is going to cause cerebellar problems, so ataxia, tremor. A cranial nerve problem is going to cause things like diplopia, loss of vision, loss of hearing in one ear is something that happens. So a wide range of distribution. There's no definitive test for MS. You know, this is really a mystery disease in so many ways, despite the fact that it's been recognized for so long. MRI is usually how the diagnosis is made. An area of abnormality or demyelination on MRI is sort of definitive for, or not definitive, but suggestive of MS. And then for treatment, you know, here's where we get into our pessimistic part. No definitive treatment. There's some research trials. I'm sure that since your book was printed, there are probably some new, you know, suggested possibilities for treatment. But with all of these neurologic disorders, physical therapy and occupational therapy do help. You know, the brain is an amazingly adaptive organ. So even if part of it's broken, a lot of times with some help, with some PT and OT, you can continue to do your activities of daily living, even with a deficit. So we try to help these patients overcome their deficits in other ways. So lots of treatments, just like we saw for CP. All right. So that's the first depressing disease, MS. You don't want to get that one because there's nothing you can do about it, and it affects, you know, your nervous system, which all of these do, which is probably why they're all so bad. So the next one is Parkinson's disease. It, too, is a progressive degenerative disorder, but this time it follows a very rigid pattern. You know, unlike MS that can affect anything, Parkinson's affects one particular place of the brain, and that's called the extrapyramidal motor system. So the pyramidal system is your motor cortex, okay? That's what tells your muscles to move and how to move. The extrapyramidal system tells the motor cortex what to do. So it coordinates, plans, balances, you know, all of the different muscle actions that are involved in our various, you know, human activities. So Parkinson's disease is a degeneration of that system, particularly in what are called the basal nuclei. So what you end up with is an imbalance between excitation and inhibition in the motor system. So what we get from that is we get a patient who can't control their actions, but yet is very stiff. So there's sort of a classic picture of Parkinson's disease that when you've been around a few patients with it, you can spot this, you know, in a grocery store from, you know, half a block away. So these are the classic symptoms. A resting tremor. So there's two kinds of tremors. There's an intention tremor, you know, you go to reach for something and you shake. And then there's a resting tremor where you're not using your hand, but it's shaking. So that's Parkinson's, is a resting tremor, one of the causes of a resting tremor. They call it a pill rolling tremor because people will do this like they're rolling a pill in their hands. So that can be a tremor as well in Parkinson's. Their faces are very expressionless, sort of rigid, so they call them mask-like. They don't blink as often as normal people do. Their facial expressions are, their face is sort of hard because of this imbalance in the motor system between excitation and inhibition. They live kind of flexed, so they stoop over, and then their elbows and wrists are flexed, and then their knees and ankles are also flexed. So they have this sort of look to them from this flexion. So when you see patients who look like this, and then when you see them walk, they kind of shuffle. They don't pick up their feet, and that's because it's hard for them to move their muscles. That's classic Parkinson's disease. So shuffling gait, pill-rolling tremor, hunched over, mask-like faces, and flexed joints, slightly flexed joints. And they're very rigid. You know, these people have like no flexibility because their muscles are sort of all tense all the time because of this imbalance. All right. So other things you see, their voices change because the muscles in the larynx are also tense. So they sort of have a low, not so much a whispery voice, just a low voice. Chewing and swallowing become difficult because the muscles don't respond like they should, and those are skeletal muscles. So we have to be worried about things like aspiration, recurrent drooling because they can't control the muscles of their mouth. There are some treatments for this one, though. There's not a cure, and but there is some treatments. So these basal ganglia are dopaminergic. In other words, they use dopamine as their neurotransmitter. So if we replace that dopamine that the basal nuclei aren't making anymore we can sometimes make an improvement to the symptoms of Parkinson's disease. Now, one of the interesting things is schizophrenia and Parkinson's are sort of at two opposite ends of the dopamine spectrum. So in Parkinson's, they don't have enough dopamine, and in many cases of schizophrenia, they have too much. So these dopamine precursors or dopamine increasers can actually trigger some symptoms of schizophrenia if they're not handled well or followed well. So dopamine replacement, anticholinergics, therapies again, PT, OT, speech, to try to increase that person's abilities as high as possible, so as they continue to lose function, they're still able to live their lives at least as best they can. All right, and then we have to look for respiratory and urinary tract infections because of their reduction in mobility and their inability to cough well and things like that. All right, so that's Parkinson's disease. ALS, or Lou Gehrig's disease, is another degenerative disorder. This time it affects upper motor neurons and lower motor neurons. So essentially, ALS causes a progressive paralysis, either a spastic paralysis from upper motor neuron loss or a flaccid paralysis where the muscles are all loose from lower motor neuron problems. Cognition, though, is unimpaired. So just like CP, even though these people lose their ability to control their skeletal muscles, they don't lose their ability to think and have appropriate cognitive behavior. So it doesn't affect that. Neither does Parkinson's disease, but it is sometimes very hard to know that because the Parkinson's patient is so rigid and expressionless, it's hard to know what they're thinking, so their communication really gets impaired. So spastic paralysis and hyperreflexia, flaccid paralysis, all right. So this is the muscle weakness proceeds in a very rigid way. In other words, there's very little that can be done to stop it. And eventually, ALS causes death by respiratory failure because if you're, the diaphragm is a skeletal muscle and the intercostal muscles are skeletal muscles. So when you lose the ability to control those muscles, you lose the ability to breathe. So you're either going to die of respiratory failure or of the complications of being on a ventilator that's breathing for you. So another depressing slide, no specific treatment, not even to slow the degeneration. And this disease has been known about for a long time, but the problem with the stinking brain is it just doesn't heal well. You can't get it to grow back. You can't get it to fix itself. So once it starts to go, all you can do is sort of try to keep it from getting worse as much as you can. There is a new drug, Reluted, that's supposed to slow some of the damage. And then therapies, respiratory, occupational, physical, appropriate nutrition. Exercise and rest helps to increase muscle strength, which allows you to stay mobile longer, even as your nervous system control starts to drop away. All right. Myasthenia gravis is a very interesting disorder. It's an autoimmune disorder where the patients create antibodies to acetylcholine receptors. Now you have to reach back into your memories about Anatomy and Physiology 1 or muscle physiology and remember that what triggers a muscle to contract is an acetylcholine receptor. That's what we find at the neuromuscular junction. Well, in myasthenia gravis, those acetylcholine receptors get destroyed. No acetylcholine receptors, no muscle contraction, because there's no, the action potential doesn't ever get to the muscle. So what we see in myasthenia gravis, as those acetylcholine receptors are destroyed, is progressive muscle weakness followed by paralysis. Now, myasthenia gravis, like so many of these other neurologic disorders, it has a range. You can have a very mild case, or you can have a paralyzing, severe respiratory failure case. So it all depends on the extent of antibody damage to these acetylcholine receptors. So usually the facial and ocular muscles are affected first. So that means you can't move your eyes, so people will say that they have double vision or that they can't focus because the eye muscles aren't working. And they'll get a classic myasthenia gravis sign, which is a facial droop, where the corners of the mouth sort of hang down, almost like a stroke patient, because those muscles are not responding. All right. Because of the muscle weakness, dysphagia and aspiration are a concern. Just like for Parkinson's disease, just like for ALS, those are skeletal muscles that do swallowing and breathing. So anything that affects the control of those muscles increases your risk for problems with eating as well as aspiration. So of the three, myasthenia gravis is probably the more common one. You'll encounter in your clinical lives people who have MG or have had MG, because in most people it does get better. So the diagnostic tests, electromyography, this is going to be diagnostic because essentially myasthenia gravis blocks the contraction of muscle. So if we hook up electrodes to a muscle and we put a little current in it and that muscle doesn't contract, that is probably myasthenia gravis. And then nowadays we can test for the antibody that's the problem, that anti-acetylcholine receptor antibody. So signs and symptoms, progressive muscle weakness. So it starts particularly in the face and eyes, impaired vision, monotone speech, difficulty chewing and swallowing, head droops, the arm becomes weaker. This one sort of goes from the head down. So it starts high and goes further down. Now, most people, it sort of stops at the chest. They never get into respiratory failure. But you can get a head-to-toe effect by myasthenia gravis. So descending paralysis is sort of the thing to put in your pocket about myasthenia gravis. It starts high and then moves low. We have some treatments for this one. Yay. All right, so we have acetylcholinesterase agents. These are or anti-cholinesterase agents. These essentially increase the amount of acetylcholine present at the neuromuscular junction, which helps to combat these receptors that are being destroyed. Glucocorticoids. This is, and we know what causes this one, this is a full-blown immune disorder, or an autoimmune disorder. So by modulating the immune system with steroids, we can improve myasthenia gravis and keep people off of ventilators, usually. We can do plasmapheresis and directly remove the antibodies from the blood. Plasmapheresis is a little bit like dialysis, where essentially we take the plasma out of the patient, we clean it up from, we take everything out of it that we don't want, and then we give them their plasma back minus the antibodies. So we can essentially filter out those antibodies with a machine and a membrane. In some patients, thymectomy, that's removal of the thymus. Remember, the thymus is found in the upper chest, and it's the site of T-cell development. This helps in severe cases of myasthenia gravis that are not helped by these other things. All right, so that's myasthenia gravis. It's a problem with acetylcholine receptors being destroyed. All right, and then a couple of genetic ones. Parkinson's is genetic too, but anyway, we're not going to go back. So Huntington disease is an autosomal dominant gene. So hopefully you remember that that means you only have to have one bad gene and you're going to have the disorder. Now, like most autosomal dominant genes, it does not manifest until after the childbearing years. So usually patients are 40 plus and have already had kids before they know they have Huntington disease. So it's one of those, genetic disorders that we'll probably have a change in attitude about now that we're able to test for things much sooner. But for now, it's autosomal dominant. This one is progressive atrophy of the brain itself. So particularly the basal ganglia and frontal cortex. So that's going to involve motor control as well as personality and higher order thinking. So we get a decrease in GABA in the basal nuclei. The acetylcholine levels are low. So what we see in the patient with Huntington's disease, first, mood swings, personality changes. And that's atrophy of the frontal lobes. The frontal lobes, very much sort of make us who we think we are, at least. And those are the areas of the brain that are affected by Huntington disease. You do get some motor effects, restlessness, these patients can't sit still, choreiform movements, that's snake-like movements, so they have trouble accomplishing ADLs, activities of daily living. Diagnosis is by DNA. It's a genetic disorder, so the easiest way to test for it is to look for the gene. And usually when the gene's been identified in the family, everybody else in the family goes ahead and gets tested too to find out if they have the disorder or not. There's no therapy on this one, so it's all symptomatic. You try, again, occupational physical therapy to try to help them stay independent and functioning as long as possible. All right. Let's do a question here real quick, and I think we're almost done. All right, the classic manifestations of Parkinson's disease are which of those things? And for those of you who came in a little late, I'm hurrying a little because people want to go and vote before the polls close at 8. So I'm trying. While you're answering, I'm going to see where I am. Okay. All right, good. That is B, resting tremor and skeletal muscle rigidity. And you could add that, the shuffling gait, the mask-like face, all those are classic Parkinson's disease traits. Once it's in its sort of full-blown Parkinson's disease, it's very easy to spot because of the very common commonalities between patients on it. All right. So dementia. Dementia is a progressive chronic disease that primarily affects cortical function, particularly what we commonly refer to as higher order functions. So things like thinking, judgment, learning, problem solving, memory, being oriented to person, place, and time accurately. So in dementia, we see confusion, memory loss, very often behavioral and personality changes. An example of dementia is Alzheimer's disease or Alzheimer's dementia, which we're going to talk about in a minute. But when you think of your typical Alzheimer patient, that's dementia with maybe a little more memory loss than occurs in some of the others. So it's a decrease in cortical function. There's 3 main causes. One is vascular, particularly patients with uncontrolled high blood pressure. They have basically little mini strokes all the time, or they have had many strokes in their life. And in some, when you've had lots of little strokes, you can start to have effects like you had one big stroke. And one of those effects is, they call it multi-infarct dementia. So many different vascular insults to the frontal lobe and to the cerebral cortex can result in dementia of varying types. Infections can cause dementia. Encephalitis is the classic example of this. We're going to talk a minute about HIV, but that's just one type. There are a number of viruses that can cause dementia by basically making the brain itself sick. Now, thankfully, those are not very common in this country, but in other countries, like in the tropics, they have a much higher incidence of things like yellow fever and sleeping sickness and things like that. And then genetic disorders can also cause dementia over time, genetic progressive dementia. So Alzheimer's disease or Alzheimer disease is a specific form of dementia. It results in progressive cortical atrophy. So basically, the cerebral cortex shrinks. It gets smaller and smaller as nerve cells die and as the connections between nerve cells get to be less and less. So we see that. We see the brain get smaller on MRI or grossly. If you look at the brain of an Alzheimer patient, it is physically smaller and less complex in its wrinkles. A classic sign in microscopically is a neurofibrillary tangle. Alzheimer patients create a protein that ends up getting lodged in neurons, where nobody knows exactly why that is associated with Alzheimer, but neurofibrillary tangles and plaques are a common diagnostic sign under the microscope. In the absence of those, there is not a definitive diagnostic test. Alzheimer is really a diagnosis of exclusion. So you have to eliminate all other possibilities for dementia before you can make this diagnosis. And this is a good thing because the more common reasons for dementia are medication problems. Medications have, the elderly person so gorked out, so to speak, that they seem to be demented, even though it's really medication-induced. It can also be depression. Depression in the elderly can very much look like dementia. So before we make the diagnosis of Alzheimer's disease, we do a psychological history and a very careful medical history to make sure that there isn't something else going on. We don't know exactly what causes it, but we do know that on several chromosomes there are many repeated DNA sequences, which may be associated with the neurofibrillary tangle part. So what we're looking at here, this is a little bit of brain tissue. You can see some cell bodies here. This bundle of fibers right here is one of those neurofibrillary tangles. So classic Alzheimer plaque, we call it. All right. And then here's showing you that atrophy. Here's the brain of the Alzheimer patient. Here's a normal brain. You can see the difference in size. And if you look closely, you can see that the wrinkles or the gyri are smaller in the Alzheimer patient than in the normal brain. And that's exactly what would happen as you lose cortical neurons. The surface area would contract, which means you'd have less wrinkles with narrower gyri and then more space in between the gyri or the sulci. All right. So the signs and symptoms of Alzheimer's disease extend over 10 to 20 years. This is a long-term illness. And I know that many of you have already heard about Alzheimer's, so we can probably just skip this because you're already familiar with what the symptoms are there. There is no treatment. Anticholinesterase drugs seem to help, particularly early on in the illness. And then, again, therapy. Occupational therapy, psychologists, speech therapy. You want to keep the Alzheimer patient as involved in their life as possible for as long as possible. So we go with a team approach that includes care for the patient as well as for their caregivers and family. Other kinds of dementia, vascular dementia we already talked about. That's multi-infarct dementia, where many small brain infarctions over time. This is common in people older than 70. So there's really no such thing as the dementia of old age, but the most rational explanation for what we see, that as people get to be very elderly, they're not as sharp cognitively, it's probably multi-infarct dementia. That over time, you're going to have some little strokes in the brain. They're going to affect your cognitive function. So it has kind of an insidious onset. Prevention is control the hypertension, and also it's been shown that people who sort of use their brains keep their brains for longer. So you want to encourage elderly people to be involved in cognitive activities, like needlework and crossword puzzles and Scrabble and chess and all those things, because it actually helps to stave off that dementia of old age. All right. Your book just uses AIDS as an example of an encephalopathy, or an infection that invades the brain and causes, in this case, a form of dementia. So this is a direct effect of HIV. A lot of HIV problems are from secondary infections, but this is the HIV virus itself eventually attacks neurons. When the helper T cell level gets to be low enough, the virus starts to invade brain tissue. And along with that, we see, what we'd expect, really, a loss of memory, loss of cognitive ability, impaired motor function as the motor cortex is invaded. Kids with HIV that have gotten congenital HIV or HIV from mom, they have AIDS dementia at a much faster rate and at a much higher prevalence. In some ways, HIV is particularly nasty to kids. A lot of kids don't live past their 4th year of life with HIV, and in part, it's due to the dementia. So severe developmental delay. The brain is very often affected in kids, probably because their immune system really never had a chance to develop right in the first place. And then our last topic, again, is one that I know you've heard of before. This is a herniated disc. So in the normal vertebrae, there's 2 parts to the disc. There's the annulus fibrosus, which is a sort of round, tough cartilage. And then inside, there's this sort of gel-like stuff called the nucleus pulposus. And when this joint here is stressed, the pulposus can basically bust out of the fibrosis and then sort of impinge on the nerves. So here's the spinal cord. Here's spinal nerves that are going to come out and innervate like the leg, for example, if this is the lumbar area. Well, this herniation pushes that nerve up against the bone behind it and basically compresses that nerve. That causes shooting pain, pain that shoots down the back of the leg. That's called sciatica. It can also cause muscle weakness, sensory deficit, anything that this nerve is bringing into or taking out of the spinal cord in terms of information can be affected by that. So the treatment for the herniated disc, prevention is a big one, which really isn't on here, but they occur more commonly as you get older and with obesity because there's more forces, there's more stress put on that intervertebral disc. And then it's usually due to trauma or poor body mechanics. In other words, not lifting correctly. You're supposed to lift with your legs, not with your back. When you lift with your back, you might blow out an annulus fibrosis. Yeah.
Does this damage the nerve? Or
It can if it's not remedied.
Okay.
Yeah, because like we've been saying, nerves don't grow back. Now, that would be a pretty significant one because it would have to squeeze it to death.
Fix it or they don't fix it. It's just
Yeah. Usually it's not enough pressure to cause nerve damage, just symptoms. Let's see. And then, so diagnosis, CT, MRI, treatment, reduced weight bearing, try to get that joint to heal, get the annulus fibrosis to heal back around that thing, heat, ice, traction, PT and OT, and then in severe cases, surgery. A lot of patients want surgery right away, but they don't really realize that all back surgery is a big deal. Even getting to the back to do the surgery requires cutting a bunch of muscles. You're in close proximity to the spinal cord, so they don't want to do surgery. They want to do surgery only when nothing else has worked. So the surgery there is laminectomy or discectomy. They basically take out that disc, and then they fuse the 2 spinal vertebrae together so that now there is no disc between them. So you lose a little mobility, but you can never have the problem happen again. All right. Let's just call it right there. There, I got you out 15 minutes early. Plenty of time to go vote, so go vote. And I will see